In the most recent version of Blood, I believe it was published last week, we presented our data on Umbralisib, which is a next-generation PI3K inhibitor specifically studied in patients who are intolerant to either a BTK inhibitor or a prior other PI3K inhibitor. So this was a phase 2 multi-center study specifically trying to address the question of intolerance. And this is a major issue when you think about drugs like ibrutinib or other PI3K inhibitors, where you can see discontinuation rates ranging between 40%, for example, with ibrutinib in the frontline setting at 5 years, and even higher with PI3K inhibitors, where probably more than half of the discontinuations are due to an intolerance event. In the setting for PI3K inhibitors, for example, pneumonitis, colitis, transaminitis, or infection. For BTK inhibitors, that could be AFib, a flutter, rash, arthralgias, hypertension, infection. And there's a longer list, but those are the most common. In that setting, you're specifically dealing with a situation where the patient has responsive disease to a class, so there's activity, but you're giving up on the drug because of an adverse event that was intolerable or life-threatening for the patient. So the study we conceived was trying to use Umbralisib in the situation of intolerance to potentially continue on a line of therapy, specifically inhibiting B-cell receptor signaling without the need to switch to other classes of drug. The take home from the study was that Umbralisib was well tolerated. The discontinuation rate due to an adverse event for Umbralisib was approximately 12%. So even in a population where 100% of the patients had to discontinue a prior targeted therapy due to an AE, only 12% had to do so here. We saw that responses were durable. We report the median PFS of approximately 23 to 24 months. And so this does appear to be a reasonable option in terms of sequencing to go from, for example, ibrutinib to Umbralisib or idelalisib to Umbralisib to continue a response for a patient in the setting of intolerance and not resistance. The caveat to all of this is that Umbralisib is not approved for CLL in the US. This would be considered off-label use of the drug, but in the context of the clinical trial specifically, this did appear to be a successful strategy. In CLL, where we're dealing with therapies, none of which are thought to be given with curative intent, the optimal sequencing of novel agents is a very important research topic. And this is one more small piece of information that's helping to guide what's the appropriate sequencing strategy for patients to provide them with the longest duration of response and therefore the best quality of life.